Hey, welcome everybody to our Accelerating Your Actions session today, Improving Health Outcomes by Taking Texas Tobacco Free. We're really happy to have you today. This is part of a series that Dr. Cruz will describe a little bit more. Today, our focus is on the connection between smoking and health outcomes. We've talked a lot, both I'm sure from your own knowledge as well as the research that the impact of smoking has been very well documented, but despite that, in 2020, approximately 14.7% of adults in Texas reported that they still smoked. And then this prevalence has only increased actually with youth. And then there is also the risk for many adverse health outcomes, including high blood pressure, uncontrolled hypertension, cardiovascular disease, and stroke. And so we're really excited to have our partners here with Taking Texas Tobacco Free to talk with us a bit more about that topic. So a bit for webcast instructions. So if you do have any challenges, please feel free to give our IT team a call. All participants will remain on mute throughout the session, but please, if you have any questions or comments, please feel free to use the chat, or you can even raise your hand as this is a Zoom meeting instead of a webinar. So we really encourage your active participation.
So welcome again. My name is Roxana Cruz. I'm the Director of Medical and Clinical Affairs here at TACHC. We really enjoy providing you with training and technical assistance. Most of this is from requests from our health centers and a lot of their responses based on their needs. So Accelerating Your Actions Clinician Series, this is the spring series of 5. So we are today 3 of the 5. TACHC is partnering with key collaborators to offer this clinician series, Accelerating Your Actions. Basically, we're accelerating or trying to support the work you're already doing. And these are facilitated discussion opportunities to help your clinical teams connect with partners and peers and develop strategies that improve patient care and strengthen your workforce. So with that, I just want to mention that, again, this is the 3rd of 5 this spring. We have 2 more coming in March, and we'll describe this at the end of March and April, and then we'll have a series in the summer for you. So with that, and no further delay, I'm passing it back to Aniela to introduce our guest speakers today.
Thank you, Dr. Cruz. So we're excited to have our partners from Taking Texas Tobacco Free and Integral Care. So first, Kimberly Skeen. Kimberly has been a nurse for 16 years with a focus on working with underserved populations. She'll be recruiting rural health centers and substance use centers and assisting in staff education and implementation of tobacco-free policies with Taking Texas Tobacco Free. We also have her colleague, Bryce Kybars. Bryce has spent over 18 years of providing tobacco treatment and policy advocacy, ranging from state universities to community and statewide coalition initiatives to nonprofit community healthcare and behavioral health systems. Currently, Mr. Kybars serves as the project manager for Taking Texas Tobacco Free, an academic community partnership to implement evidence-based, multi-component tobacco-free workplace programs at community behavioral health and substance use treatment centers across Texas. Through this project, Mr. Kybars has trained over 7,500 clinical providers on treating nicotine dependence and provided technical assistance to 35 agencies to implement comprehensive tobacco-free workplace programs. Mr. Kybars has a master's degree in counseling psychology. So once again, we're very excited to have this team present today. And I'm gonna let Kim, if you wanna go ahead and share your screen.
Sure.
Excellent. You're good to go. Thank you.
All right, so just a little bit about our mission. So we want to promote wellness among Texans, and we are an academic community collaboration between the University of Houston and Integral Care, and we are funded by CPRIT, so the Cancer Prevention Research Institute of Texas. As you look through the agenda and topics today, just a reminder that healthcare providers do play a key role in decreasing tobacco use. With smoking cessation tools and resources provided during this training and throughout the TTTF project, you can ensure that you and your patients have the resources needed for a successful quit journey. So smoking is the leading cause of preventable death and disability in the United States, causing more than 480,000 deaths each year. That accounts for about 1 in 5 deaths that's related to smoking. And smoking and tobacco use also cuts the lifespan of people with serious mental illness by between 5 and 15 years. So to put this into perspective, each year tobacco kills more Americans than alcohol, car accidents, prescription and illegal drug use, AIDS, murder, and suicides all combined within the United States. For cardiovascular disease, heart disease, coronary heart disease, sort of what's the difference? We tend to use these terms interchangeably, but there are differences. Cardiovascular disease is really the big umbrella, the term that we use for all types of diseases that affect the heart or blood vessels, including stroke. The most common type of heart condition in the US is coronary artery disease, which occurs when the walls of the arteries develop atherosclerosis. So that's the hardening and narrowing of the arteries due to plaque buildup. This can lead to multiple problems, including chest pain, heart attack, congestive heart failure, arrhythmias, and stroke. The physiology behind that, cardiovascular disease, it accounts for about 1 in 4 deaths that are directly attributable to smoking. That's because it changes our cholesterol levels. So it elevates the levels of low density lipoprotein, LDL, or the bad cholesterol. It elevates our triglycerides, or the fat in the blood. And then it also decreases the high density lipoprotein. So the HDL, or the good cholesterol, decreases. It also causes hypertension, and that's due to the thickening and narrowing of blood vessels. And then we also see an increase in plaque buildup. So not only is there an increase in the plaque buildup, but it can also rupture and lead to a thrombus or a blood clot. And then these clots can also break off and move to other parts of the body, and that would be an embolus. The effects of smoking on blood pressure are complex, but evidence shows us that tobacco smoking increases blood pressure acutely, and it increases the risk of renovascular, malignant, and masked hypertension. The joint occurrence of tobacco smoking and elevated blood pressure has enormous health consequences. The chronic effects of smoking on high blood pressure are still being studied, but both smoking and secondhand smoke exposure are known to increase the risk for the buildup of plaque inside the arteries. This process of atherosclerosis is accelerated in the presence of high blood pressure, and we know that each time a person smokes, it does acutely increase blood pressure. Even if a person doesn't smoke, the effects of secondhand smoke can have serious cardiac health consequences that could result in death. Secondhand smoke accounts for about 34,000 deaths each year. And for non-smokers exposed to secondhand smoke at home or the workplace, the risk of heart disease increases by about 25 to 30%. And then stroke risk increases by 20 to 30%, resulting in about 8,000 deaths per year. Secondhand smoke includes smoke burning from the end of the cigarette, in addition to the smoke that's breathed out by the smoker. And there is no safe amount or risk-free level of exposure. One way to help both smokers and non-smokers is to incorporate a tobacco-free policy. So having a tobacco-free work site has numerous benefits, including reducing the risk of lung cancer, reducing the risk of heart disease, stroke, upper respiratory infections. It helps the institution's bottom line by decreasing medical expenditures, property insurance, and workers' compensation, decreases the cost of health insurance rates. Staff will experience fewer sick days, and a tobacco-free policy will help increase the number of quit attempts and decrease the number of cigarettes smoked per day. It also encourages abstinence from other substance use or abuse. 2020 Surgeon General's report shows that about 70% of adult smokers do have the desire to quit, but over 40% of those same smokers are not receiving advice to quit from their healthcare professionals. Many providers are reluctant to address tobacco use. Some of these reasons include a reduced confidence in their ability to deliver tobacco cessation treatment, a lack of necessary knowledge and training about cessation treatments, and then sometimes it's feeling like someone else will take care of this. This might not be the right time to address it. So how do we overcome these barriers? Providers can help implement tobacco-free workplace policies that are inclusive of all forms of tobacco. We can educate staff on tobacco use and its health consequences, educate staff on cessation methods to empower all levels of providers to feel comfortable having those conversations. We want to utilize the 5 A's to assess for readiness and then arrange appropriate follow-up. provide appropriate treatment resources and medications to increase the quit attempt success rates, and then encourage patients using trauma-informed and motivational interviewing techniques. So hopefully with more education and awareness, we can be part of the solution to help providers overcome these barriers, help patients get the treatment and medications that are right for them. Today, we'll review some motivational interviewing basics and how to better engage with and assist a patient to make a quit attempt. As a quick recap before moving into MI, we'll review ACEs and trauma-informed care. So ACEs are negative or potentially traumatic experiences that occur during childhood, and they're associated with risky behaviors, including smoking. The risk of becoming a daily smoker accumulates as the number of adverse events increases. So clinicians want to be aware of and sensitive to this when speaking with tobacco users. Along with understanding of ACEs, healthcare providers should embrace how an individual's past and current experiences may lead to risky behaviors and health consequences. Trauma-informed care helps us employ this. It's not accomplished through any single technique or a checklist, but by utilizing these 6 principles, we can help prevent re-traumatization during tobacco treatment services. And examples of how to incorporate these principles in tobacco cessation services can be provided as a separate resource. If a tobacco user is currently unwilling to quit, clinicians should still be having these motivational discussions with patients. Even asking could make a difference and increase the likelihood of making a quit attempt in the future. So we want to ask every patient at every visit about their tobacco use. We want to advise them using direct language. We want to assess their desire or their willingness to make a quit attempt and let them know that it doesn't have to be the same day. You know, you could ask, do you have a desire to quit using tobacco in the next 30 days? You want to assist those who have a desire to quit to access treatment resources and make sure that those resources are helpful for the individual in their unique circumstances. And then you also want to arrange a follow-up session to check in on their progress, address any roadblocks or barriers that have come up. And this could be as simple as a phone call or a patient portal message. And Bryce, over to you.
All right. All right. Well, thank you very much, Kim. So now what we'll do, we'll talk about some of the motivational interviewing basics. And we also have Dr. Lorraine Reitzel on the call. So Lorraine, if I get stuck or if you'd like to add something to this, Lorraine is an expert in MI and training in MI. So please jump in if at any point you want to add something. So one thing from that we know about motivational interviewing is that it works really well to help folks who they're not really sure if they want to make a change. And this change could be from taking their medication on a more consistent basis, exercising more, losing a little weight, eating healthier, cutting back on their alcohol use, or in our case, stop using tobacco products. And a lot of times when people want to make these changes, they have a lot of ambivalence. They are ready to change, but they're not really ready to change at this point. And so MI kind of helps moving people along that continuum to become more ready to make these changes and prepare themselves to make these changes. And essentially what the primary goal is to elicit change talk. We'll talk about the difference between change talk and sustained talk. And ideally what we want folks to do, move from this sustained talk, which kind of focuses on the problem or the status quo or where they're currently at and why they shouldn't change, to identifying reasons and processes and positive aspects of their life that'll allow them to make some changes. Some of the underlying perspectives of motivational interviewing, first and foremost, is that it needs to be a partnership, or should be a partnership between the clinician and the patient or the person that wants to make this change. And the way that's been related to me is that it should be more of a dance rather than a wrestling match. If we're polling people and trying to get them to make that change, and we're actually doing more work for the patient than the patient is putting forward, that's probably not the best relationship that we want to be. It's not a true partnership. So we want it to be that give and take where they're contributing the effort and the work and the ideas, and we're helping them through that process. Also having this genuine belief and acceptance that that they are able to make some of these changes, that they have this absolute worth and have an accurate empathy for what they're experiencing, providing affirmations. And we'll talk about affirmations a little bit later in this presentation. There's a difference between providing accurate affirmations and kind of cheerleading and giving people support. And so we'll kind of talk about that. The evocation is that they already have the motivation, the resources within them to make these changes. And now we just have to help them bring that out and kind of guide them along that process. And then having that compassion for them and that we have their best interests in heart. So I think these are all very, very important perspectives to keep in mind as we have conversations with them in utilizing some of these skills. I think it's also important to recognize that, and Kim kind of mentioned that in the 5 A's, that everybody that we have conversations with regarding their tobacco use, they're not going to want to quit. They don't have an interest in quitting. And some folks will be very blunt and say, I don't care. I don't want to talk about this, right? At least we know kind of where they're standing. But then others will fall on this continuum of, well, yes, I know it's bad for me, but I know I should quit, but I'm not ready right now. This isn't the best time, and whatever that might be. And it's okay for us to, and it's okay for them to be in that spot. But what I think is important is that utilizing motivational interviewing techniques and skills, we can help people move people from not being willing or interested in quitting or having that ambivalence to actually making some progress and leading up to a quit attempt and being successful in quitting. And I think it's important to know that this is a cyclical process and that folks will move forward a couple spaces and then possibly retreat back. I think that's one thing that we noticed with COVID, where I was kind of thinking that more people would quit using tobacco products during the COVID pandemic because of how it was impacting people's lungs and their ability to breathe and making them more susceptible to become sick. But we actually kind of saw some folks reverting back to some old behaviors and using cigarettes as a coping mechanism in times of uncertainty and stressful situations like that. So it was really kind of interesting, but that's kind of how people move forward and move backwards along this continuum of change. And motivational interviewing shared trauma response is exactly like came up in the chat. So as we kind of talk about eliciting change talk, a couple of the things we're going to talk about, we'll talk about open-ended questions in the next couple slides here. But instead of asking just simple yes, no questions, one answer type of questions, we want to engage people in a conversation to get more information from them and to solicit a more meaningful conversation with them. And I think probably if you have a good relationship with your patients, you probably already know some of their goals, their values, and their wants. And we can utilize those traits or those wishes to help them move forward to live a healthier life without tobacco products. Questioning extremes. Some folks they really kind of cling on those extremes of I can't, I shouldn't, I won't. Or this will happen if I've tried this before, right? We hear a lot of those extremes in conversations from patients. And I think we could question those and kind of bring them back to them. Always be looking forward and not backwards is a very important principle with MI. Focusing on the positive, focusing on what change do we want to see rather than dwelling on what we have tried or what hasn't worked. And as we're listening to folks talk and they're expressing their desires to make change, this is where the exploring the darns come in. And we want to keep our ears open for when people start talking or expressing this desire to change. And that might be someone just blatantly saying, I truly want to quit smoking. I am tired of using tobacco products, whatever that might be. That is a desire to change. Some folks might say, I know I can quit smoking because I've quit before. That's their ability to make that change. And then some reasons to quit. that they have. Sorry, I had a little glitch there with my screen. And then a need to change. I really need to change because it's probably more than likely a health factor that's motivating them to make that change in their life. It could be a family situation, things like that. So always keep an ear open for when they are starting to talk about some of these reasons to make changes. So to kind of help people move through these stages and to solicit some change talk within them, the acronym that we use are ORS. And really, I like the picture that we use in some of our trainings here, where we want everybody pulling as if they're rowing a boat. We want everybody be pulling in the same direction at the same pace at the same time, and that we don't have the doctor, the nurse, the counselor, whoever doing one thing and trying to get them to do one thing, and the patient or the client is doing something else. So for the ORs, we want to utilize, there we go, open-ended questions. And kind of like what we talked about a little bit earlier for open-ended questions, we want these to be questions that aren't answered with a yes or no. Sometimes we do have to ask a question that has a yes or no. Do you have a desire to quit smoking? That's kind of a yes or no question. But how else could we ask that question? I'm going to kind of open that up to folks, and you can put it in the chat or you can unmute yourself. How else could we ask that yes, no question, but make that more of an open-ended question? So instead of saying, do you have a desire to quit smoking? How else could we say that in more of an open-ended manner? So any thoughts from folks? How could you make, do you have a desire to quit smoking into an open-ended question?
I can't see anything in the chat, Bryce, but what are the 3 best reasons to quit smoking?
Okay. Dr. Wrights will put in there, can you tell me about your desire to quit smoking? So just changing that first part from do you have a desire to tell me about your desire to quit smoking. And you can really see how that, by adding, will you tell me about, how that's going to solicit a much different response than just saying, do you have? Dr. Cruz said, what brings you, what brings you to, and then kind of how do you feel about making a quit attempt? That's some things like that. Very good. What brings you here, and how do you feel about your tobacco or your tobacco use? Something like that. Very good. Very good. Some other things, using a non-judgmental tone, where we're not projecting ourselves or our beliefs onto someone. I think one way to do that is, you do want to quit smoking, don't you? That is very, smoking is very bad for you and that you should quit, right? I think that is one way that we could project that judgment upon them. And a lot of times we'll get people telling us what we want to hear rather than kind of where they're truly at. They'll say, of course, yes, I want to quit, when really they don't. They may not have that strong desire to quit. And then Annie, thank you. Yeah, so what are your concerns about quitting? Exactly. That's a very good question to ask, a very open-ended question, to generate some of that discussion and get them talking and get them expressing, give us a little bit more information. And then engage the patient and leave broad latitude for how they want to respond. So that's another benefit of using the open-ended questions. We learn a lot more about them. We learn a lot more about their interests and their desires by using those open-ended questions. All right, Kim. So for affirmations, like I spoke about a little bit earlier, basically we're affirming the patient. We're just saying that, saying things that are positive or reinforcing to them. I think this is where we can build upon existing strengths, their abilities, past efforts that they've made, resiliencies that they have within themselves. And if we have that existing relationship with them, they probably have made similar changes, positive changes in their health before. They've lowered their A1C3 measures. Maybe their cholesterol has been decreased, or they're improving their diet. They're walking and exercising a little bit more. So we can relate some of those positive changes that they've made before in their life, and just kind of reaffirming that with them. Using you statements instead of I think you are doing great, because when we say that I think, that becomes our value. And just saying you're doing really wonderful with this. You've been making great progress, whatever that might be, and kind of putting it back upon them as their success rather than our judgment of their success. By giving these affirmations, it strengthens that rapport and that relationship between the clinician and the patient or the client. And then think of affirmations as attributing interesting qualities to the patient. And I think that as we get to know folks and we do have that relationship with them, this is a kind of an easy one to really affirm with folks and to kind of bring that up and moving them forward. Some things that we might want to talk about with them as far as some affirmations, that you've been very open and honest today with quitting, and that it's not always easy. You know, I think that that's a very strong affirmation about if someone's struggling with quitting and they've been very upfront and they've talked to us about that. That's a very kind of a heartfelt affirmation. You know, even though it's difficult to quit smoking, you're sticking with your plan to cut back and kind of acknowledging that those challenges that they're facing. So the next one on the oars would be the reflections. And this is something that I've always struggled with as a counselor, even in my undergraduate and graduate. I haven't had a real good knack at giving people accurate reflections. And it's always felt kind of forced for me, and it really hasn't been a natural skill, I guess, that I've ever developed. But I think as people practice it and they become better at it and just work with folks, I think it could become very second nature for folks, and it's easier for some people than others to do some of these reflections. And so essentially, what we do is we're listening to what somebody has to say, and then we reflect it back to them in just a little bit different manner. So here's some examples listed here on this slide. Is that the client or the patient says, the only reason why I'm here is because my wife wanted me to come. I really don't want to quit smoking. And we have a couple different reflections. One would be just a simple reflection where you kind of just parrot back what they say. You really don't want to come here today. That is a very simple kind of a reflective or a mirrored reflection, I guess, if you'd want to call that. But another way that we could kind of turn that reflection into a more complex reflection, where we're also bringing in some kind of feelings and intent behind that reflection also. So one way to say that would be, you really don't want to come here today, but you value your wife's opinion. And we'll talk a little bit later here about how do we make this into kind of a double-sided reflection as well. But we'll kind of keep that one as a complex reflection for right now. Another example, I don't think I really have a problem with tobacco. And we could just kind of mirror that back to them and say, you're not sure that tobacco is a problem for you. And they'll say yes, and probably kind of affirm that with you. And with this one, hopefully we would have something else to go along with that if they said, I really don't have a problem with tobacco. But I think through conversation with them and maybe what they're experiencing, we can kind of make that more of a complex reflection, which here it says tobacco use isn't something you're concerned about. So you aren't sure that coming here is going to be helpful. And so that's kind of bringing that intent along with that reflection of that simple reflection. So you don't think this is going to help you out, or this isn't very, very useful for you. So when we talk about making a double-sided reflection, one thing that we kind of look at with that is looking at kind of the good and or what they're struggling with, and then what's the positive that could come out of attending, or why are they here? Why are they having this conversation? And so one way that we could make the first one kind of a double-sided reflection would be that if they say, they say, you know, the only reason why I'm here is because my wife wanted me to come. I really don't want to quit smoking. Say, you don't see your tobacco use, or I'm sorry, you really didn't want to come here today, and you understand making this effort's important to your family, right? And so now you're really putting that value of not only my wife wanted me to come, but I value my wife and I value my family, and they're very important to me. And so that's why I am coming. And one thing with kind of some of these double-sided reflections is using the word and instead of the word but. And in the example here for the complex, we use but when we use the word and, that adds value to the second part rather than but. And I think we've all been a part of some of these conversations where people say something like, I really like you, you're a very nice person, but, and then we go, oh, we know what's coming after this, a criticism. And so then we discount that first part of something, and we just kind of hear that second part. So I think using the word and is very important. So in the example that I gave, you really don't want to come here today, and you understand making this effort is important to your family. And so I think that if we would have put but in there, but coming here is important to your family, it kind of downplays that second part of that reflection. So for the second reflection, you don't see your tobacco use as a problem, and yet you continue to come to meet with me to help you quit, right? But if we would have said, but you keep coming to see us to help you quit. So just using the word and instead of but, I think that's a really important kind of separator when we do some of these double-sided and complex reflections for folks. With the summaries, I'm sorry here, I'm looking at a few things. So with summaries, what we want to do is kind of just put everything together, and one in the training that our staff do and that Dr. Reitzel has conducted is it's kind of cool with our summaries, because we kind of pick and choose what we want to put in a summary. We don't have to summarize everything that a person says, the good and the bad. And one of the things that they kind of talk about is that you can pick out whichever flowers you want to put into a bouquet. You don't have to put every flower available into this bouquet. And that's very similar with the summary, is that you can kind of pick out what parts you want to summarize. And although some people, they might talk about kind of how they're stuck in this problem, but during that, they've also talked about how they want to move forward. And in that summary, we can get rid of all the talk about how they're stuck, and we can pull out the 2 or 3 parts of how they want to move forward in that summary. So collecting material that's been offered so far, you've expressed concern about how smoking impacts your children, your health, and your finances, or finding housing, whatever that might be. And maybe before they talked about those concerns, they were talking about how they didn't want to quit using tobacco products, and because it was helping them with their stress or helping them deal with their anxiety. We got rid of that, but we talked about how it's really impacting their family and their health and their finances. Link something that was just said to something that was discussed earlier. That sounds a bit like what you told me your husband said about smoking. You know, so drawing on past conversations. draw together what has happened, transition to a new task. And I think that this is really good as we're moving forward and transitioning, is that we kind of summarize everything, put in that nice bow, and then moving forward with something else. Before I ask you the questions I mentioned earlier, let me summarize what you've told me and see if I've missed anything important. You came in because you're feeling, and then so on and so forth. So I think that's a great way to kind of just put it all into kind of put a bow on it and then move forward. It's important to ask follow-up questions for clarification. And one thing that's really nice, sometimes we're kind of afraid to do this and ask some follow-up questions because folks might contradict us or say, if this is accurate, what other points are there to consider? And someone say, well, no, that's not what I meant by that. And so if we are kind of incorrect in some of our summaries or even in some of our reflections, folks will correct us and say, well, no, that's not really what I meant. What I meant is, and then they can restate it. And then, like it says here, anything you want to add or correct through our conversation. So after we've kind of had some, and the other thing, this might sound like a lot for a conversation, but it doesn't have to take a long time. Some people think that I don't have time to do this. I don't have time to have these conversations. It's not that we're sitting down and having a 10 or 15-minute conversation. We can have these conversations maybe 3 to 5 minutes and kind of addressing some of these things and summarize. All right, we talked about A, B, C, and D. And we've agreed that we want to talk about this at our next session or at a follow-up appointment, something like that, where you're going to call the quit line or you're going to seek out some nicotine replacement therapy, whatever that might be. And so part of that is creating that next step or that plan. So kind of what do we want to do next is a great question. What would be the first step? How can I help you move forward with this, And if we leave it too open-ended, they might not have any idea what to do. And so we might have to offer them a menu of options saying, to help you quit smoking, we have some individual groups or some individual counseling. We have some group counseling. I could make a referral to the quit line and have a quit coach call you or access some nicotine replacement therapy here at the center. I think picking out maybe 3 or 4 things instead of maybe 7 or 8 different options for them, they might feel a little overwhelmed. So kind of, once again, picking and choosing what might be best for your patient. Because by giving them some of those menu of options, it eliminates guessing and just trying things. Some folks might say, well, I'm going to go out and do so-and-so. I'm going to go buy an electronic cigarette and help me quit smoking. That's probably not the best option that we want them to take. And so instead of kind of correcting them on that, if we give them a list of options to kind of choose from, even though we might limit some of the options, it still allows them the autonomy to make that choice and direct their own care and to move forward from that point. Starting simple, not providing too many options, like I just said. Which option might seem the most possible, or what's the best place to start are some great ways to kind of have some of those conversations. Like Dr. Reitzel says, it's very validating for the person when we kind of move forward with them in this manner. Recognizing and acknowledging the ambivalence and uncertainty, just being very open and honest, kind of goes back to some of the, and very transparent, which goes back to some of those guiding principles of trauma-informed care. And maintaining that's their plan and that it's not our plan. And one thing I think sometimes happens that people feel like they need to quit for us, and not only for them, but also for us as the healthcare provider or as their counselor, whatever that is. And really kind of bringing that back on them, that they're making this change for themselves in their lives. So I think next we have a short video here, and I'll kind of set up this video. This is a doctor talking to a mother who's coming in for her son has had multiple ear infections. And then the doctor noticed that the mother is a smoker. And so she broaches the topic about her interest in wanting to quit and how that might be impacting her son Aiden's ear infections. And this is a scenario. Okay, we'll just play it.
Kim, we can't hear the sound.
To find a solution.
Oh, no, we can now.
So I wrote a prescription for antibiotics for Aiden. I did want to talk to you though. I'm a little bit concerned looking through his chart at how many ear infections he's had recently. And I noticed that you had checked the box that someone's smoking in the home. So I was wondering if you can tell me a little more about that.
Well, it's just me and him, and I do smoke. I try really hard not to smoke around him, but I've been smoking for 10 years, except when I was pregnant with him. But it's so stressful being a single mom and having a full-time job. And so that's why I started smoking again.
You have a lot of things going on, and smoking's kind of a way to relax and de-stress.
Yes. Yeah. Some people have a glass of wine. I have a cigarette.
Sure. And it sounds like you're trying not to smoke around him. Why did you make that decision?
I know it's not good for him. I mean, I've read those things about ear infections and asthma and stuff, but other kids have ear infections and their parents don't smoke.
So on the one hand, you're worried about how your smoking might be affecting him. And on the other hand, you're not so sure if it's really the smoking that's causing these problems.
Right. Yeah. I mean, he doesn't have asthma. He hasn't had a lot of other problems that his other friends have. So, and I've thought about quitting before in the past, but I just don't see how it's possible right now.
What made you decide to quit smoking when you were pregnant?
Well, he was inside me and we were sharing everything, and I knew that he would get some of that, and I just didn't think I could live with myself if something happened to him.
Right now, though, it feels almost too difficult to even manage or even to try.
Yeah, exactly.
How were you successful when you quit before?
I don't know. I think about it now. I don't even know how I did it. I just did it. You know, I just couldn't imagine like him not being born or going into labor early and him having problems and stuff like that, all the stuff that they talk about with women who smoke. So that was just enough to say, okay, you know what, I'm not going to risk that.
Mm-hmm.
So
the risks were so scary then that you were able to stop.
Yeah.
They don't feel as scary to you now.
No, I mean, we're two separate people. And like I said, I try really hard not to smoke around him. I'm pretty good about that. I don't let other people smoke around him. So
you're doing the best you can do.
Yes. Yeah.
Okay. But it sounds to me too, like part of you really does want to quit.
Yeah, I know that I need to. And I keep every new year, I say, okay, this year I'm going to quit smoking, but then something happens and it just doesn't.
It's on your to-do list. It's just not making it to the top.
Yeah.
If you did decide to quit, on a scale of 1 to 10, where 1 is not at all confident, you don't think you could do it, and 10 is you feel pretty certain that you could, where do you think you fall right now?
Probably like a 5. Kind of in the unsure area. Mm-hmm. Like I know I've done it before, so I know I can do it, but at the same time, it just seems really hard, and it's not the same situation.
Well, what made you say 5 rather than 2 or 3?
I know all the ways it's bad for me, and I don't want him to grow up thinking that it's okay to smoke. I don't want him to use any kind of, I don't want him to chew or anything like that. So I know I need to, especially before he gets old enough to understand what mommy's doing, but I just don't know if I can do it.
Okay. So it sounds like you have a lot of reasons why you'd like to quit. You have been successful quitting in the past. And right now you're just feeling a little bit hesitant about your ability to do it.
Yeah.
Where do you think we should go from here?
I don't know. I'd like some help. I just don't know what kind of help I need.
Sure. Well, if you'd be interested, that's something I can definitely talk to you about. There are a lot of new options that can actually help people be way more successful in their attempt at quitting. There's different medications you can try.
I don't like medicine.
Okay. There's also a lot of support groups and classes that you can take where you have other people to go through it with you. And sometimes just having that support can be a big part of it, especially for people like you where smoking is such a stress reliever.
That sounds nice, but I'm not sure if I have the time for all that.
Sure. It feels like something that would take up a lot of time and maybe not fit into your life. I wonder if we could talk about some options that might fit into your life.
That would be really nice.
Okay, well, if you're willing, then we could set up another appointment where you could come in and we could talk more about that.
I would like that. That would be great.
Great.
Thank you.
Sure.
This time.
Very good, very good. All right, so now I would like to open this up maybe for the next 5 minutes or so, just to kind of debrief with this. And well, what did you see happening? What did you see was good listening? What were some of the MI skills that we talked about during this presentation came up, and some things like that? So if folks want to unmute or throw it in there in the chat real fast.
I've never seen this video before, but I really liked the way she reflected a lot of what the patient was saying, particularly making sure she always chose the things that were in the direction of change. And I liked how she used the importance ruler, like, because she switched from, they were kind of in the space where, yeah, I'm not ready to do it now. I don't really want to do it now. And then she had her put it on that scale of importance, and then was able to say, well, it's kind of in the middle. Why is it in the middle and not at the beginning? And then that generated even more change talk. I thought that was really good.
Mm-hmm. Mm-hmm. Yeah, she really, the patient really kind of made her work hard to bring her back to that change talk. That was I thought the doctor did a really good job of bringing that conversation, moving that conversation forward rather than getting stuck in just kind of rehashing old information or why she doesn't want to make those changes. Very good. And Annie said she actually listened to her, and that it's amazing when we just listen to what folks have to say and we have their true interests at heart, how much of a big difference that takes. And Lorraine said didn't force the meds. Exactly. And right at the very end, when she did that, she did a great summary. And she put kind of everything, the good and the bad, and kind of where the patient is. And then she said, well, what are the next steps? And she offered a couple of menus, and a couple of her next steps were shot down right away. I don't want to take the medication. I don't have time for the groups. And so once again, we're kind of getting stuck in that sustained talk. And I thought that the doctor did a great job of transitioning. Well, let's identify some other options in another conversation, and how can we move forward with this instead of it being this power struggle of give and take of, well, you have to do something, but you're not being willing to do this. And she just said, okay, well, let's kind of table this. Let's think about some other options, and let's make another appointment to discuss this in another appointment. So I thought in the end, she did a pretty good job of kind of walking that fine line there with her. And in the presentation, I think that we provided to you, we only showed you kind of the effective doctor talking about this, but we have one. There's another video in the presentation that's available where the doctor uses some really ineffective skills where she's not really listening and driving home a lot of judgments. And so you can kind of compare that ineffective conversation with this effective conversation too. So please check that out when you have some time. Any other thoughts about the interaction between the doctor and that patient?
I just wanted to comment that a lot of times as clinicians, we have this agenda that we need to address and take care of. And in this case, the listening was very in tune with the patient. So they paused long enough and let the person express themselves. A lot of times, because we have so many things to take care of at that time, we lose sight of that. And that's when we actually lose the patient as well. So I just wanted to comment on that.
That's exactly right, Dr. Cruz. And when I was working at an FQHC here in Austin, and I would talk to our doctors about addressing tobacco use, they say, I don't have time to talk to them about, I'm talking to them about their high blood pressure. I'm talking about their cholesterol. I'm talking about their diabetes. And it's like, that's fantastic. And I completely understand that. But how could we put the tobacco conversation in there? How is their tobacco impacting their diabetes? How is tobacco making their hypertension worse? How is it impacting their cholesterol? And that we can have these conversations. And this is a great example. The mom came in because her child's having ear infections. She didn't come in to talk about smoking, but the clinician made it a point to build to have a discussion with the mom about her tobacco use and how that might be impacting her child. And so having that conversation, it's very easy and possible to intertwine these conversations into many existing visits that we're having with folks. All right, I think, so does anyone have any questions, any comments about information that Kim presented, about information that I presented on motivational interviewing? I think we have about 3 or 4 minutes for some questions, some comments, anything else that folks might have.
What if folks do want to help their health center move forward in becoming a tobacco-free space, learning more, getting in touch with you? What do they do?
Right. All right. So presently we're recruiting through, and as Kim said earlier, we received funding from the Cancer Prevention Research Institute of Texas. And so we're contracted with them to work with 10 rural health centers across the state. We have 3 health centers have signed MOUs already. So we're recruiting another 7 centers presently. And essentially what we do is we can help centers implement a 100% tobacco-free policy if they don't have one already. We assist centers to integrate tobacco screening and assessments into their clinical processes. So obviously in that scenario we watched, they already had asked the mom if there was a tobacco user in the family. And so they had that information so she could have that conversation with the mom. And so that's what we would want centers to ask those questions, either at intake and at every visit. Providing direct tobacco dependence treatment services to those who want to quit. And we'll talk about what some of those services are that we can provide to the centers. And we ask the centers to make staff available for treatment and tobacco dependence treatment and education training. And that's a 90-minute training, which we'll talk about in just a little bit. And then to implement process, collect data to report back to us. And so right here, we're kind of talking about the 5 or 6 health centers that we're recruiting for our first cohort. And if centers aren't ready to jump on right now, we could start recruiting for our second cohort in kind of mid-2022. So July, August, maybe around that time period, if your organization isn't prepared or can't participate right now, but you have that desire, we would love to talk to you maybe a little bit later in the year or mid-year or something like that. And when we do implement this process, it doesn't happen overnight. It's about a 5 to 6, maybe 7 month implementation process to spread out the work, and kind of take it in chronological order. So what do we provide to centers when we do partner with them? We spend a lot of time and energy providing training to the staff. So the 90-minute training is for all employees so that everyone at an organization has the same information, same understanding of what nicotine addiction is, how it's impacting people, and what are the resources and evidence-based treatments to help people quit using tobacco products. That's not only for the clients, but a lot of times our employees get a lot out of that training, and they take it with them to make their own quit attempts. We also pay for a person to attend a certified tobacco treatment specialist training. This is typically a 4 or 5 day training. It's a virtual training held at MD Anderson Cancer Center, or held through MD Anderson Cancer Center. So we pay for the registration fees for that. They have one coming up in June of 2022. We have a Train the Trainer program. That's a sustainable training program for all new employees that are coming on board, that they're receiving the same education and training that the current employees have received. And then also, if a trainer quits, we can train new employees to be a trainer, so that ongoing training on tobacco dependence and education continues after the grant is finished up. Motivational interviewing training. So what we presented today is just a small portion of an 8-hour motivational interviewing training that we provide. Our next training, or our first training, is coming up on May 18th and 19th. It's an 8-hour training. So we have separated it into 2 days because it's a lot of information, and sitting in front of a screen for an 8-hour training is really hard for people to maintain their attention and commitment. So we've separated into 2 4-hour sessions. So if you participate in our project, staff can attend that MI training for free. There are some video conference calls offered through MD Anderson, and then we have various announcements on webinars. We also provide centers with nicotine replacement therapy that can be dispensed to client or patients and employees for free. So we start them out with a starter kit of about $2,000 to $3,000, maybe $4,000 of nicotine replacement therapy to kind of get them going with their project. And signage and posters. We have posters and rec cards that encourage people to quit and provide them with some resources. We have worksite, tobacco-free worksite signage. So if you have signage already for an existing policy, you want to update it or need to replace some of those signs, we can do that. But if you have no signs, we pay for the design and the creation of those signs. And then, of course, we provide technical assistance throughout the whole process. That's Kim and my job primarily, is provide that technical assistance and training and just kind of help you and guide you through this whole process. Our website has a number of different resources on it, implementation guides. We're putting together an implementation guide for rural health centers as we go through this process with centers. So the organization that we're working with play a really important role in us creating an implementation guide for health centers. But you can look at some of our past implementation guides and the various presentations and fact sheets and quit plans and videos, all these different resources we have on our website. So I think that is it. I saw that our contact information there, if anyone is interested in participating in our project, it's completely free. You can reach out to myself or Kim. There's our contact information, and there's a poll. So please take that poll that's in the chat.
Thank you so much, Bryce and Kim. We really appreciate your session today. We have, as Dr. Cruz had mentioned, we have 2 upcoming Accelerating Your Action series. The next one will be taking place on March 25th, focused on maternal health. So please register on TACHC website for more information. And then we also have our HIT clinical conference that's coming up at the end of April. And TTTF will also be there. So you'll be able to meet Bryce and his team in person, ask questions, get to know them a little bit better. And so we really encourage you to participate in that conference, and we would love to see you in person in San Antonio. We have that session evaluation poll, so we really appreciate your participation in that. And then if you have any further questions or concerns, please let Dr. Cruz and I know, and we'll be sending this out to our partners as well and folks who registered, and then our various listservs, just in case folks were unable to participate today. So thank you very much for your participation.
Thank you very much, everybody. Thank you, Dr. Cruz. Thank you, Anelia.
Thank you.
Thank you. Thank you for being such great guests. Thanks.
Goodbye, all.
Bye.